Hello, good day everyone. My name is Christine Mahinabe, a student nurse from BSN1 11J Group 38 of Davao Doctors College, and I am here to perform the return demonstration in assessing abdomen. The purpose of the abdominal exam is to get more information that could indicate what is causing the patient's symptoms. The physician gains information by inspecting, auscultating, palpating, and percussing the abdomen. For the pre-introductory phase, first review client's previous medical records and doctor's order sheet if available. This is to know if the patient has a medical history as stated in the doctor's order. The nurse must perform the assessment of the abdomen at 1 p.m. So it is 1 p.m. already and the patient is sensitive to cold temperature. So the reason why we're going to read the doctor's order is in order for us to be guided during the assessment. Second, determine the scope of assessment needed. Prepare necessary equipment such as ruler, a pen light, marker, the tape measure, and of course, the stethoscope. I will be assessing the abdomen and these are the things that I will be needed during the assessment. The tape measure, examination broom, 2 pillows, stethoscope, and I will be placing these things in the examination table to be able to save time and energy. Next is perform hand washing or don gloves if deemed necessary to prevent the spread of microorganisms. Good afternoon, ma'am. I am your student nurse, Christine from Davao Doctors College, and I'm going to be with you and to assess your abdomen. So, ma'am, may I know your name, please?
Angel.
When is your birthday, ma'am?
March 8, 2000.
What do you want me to call you?
Jalo.
Okay, I'll check your wristband. Next, explain the procedure to the client and how he or she can participate during the assessment. Provided the client the opportunity to clarify, ask, or raise any question. Okay, ma'am. So today, I will be assessing your abdomen and I am going to touch some part of your body. Is it okay for you, ma'am?
Yes.
Do you have any questions or clarification about the assessment, ma'am?
No.
Okay, so if you don't have any question during our assessment, do not hesitate to ask, okay? Okay, next, ensure the client's comfort, privacy, and confidentiality assessment SETI was assured to be safe, secured, and free from distraction. Position clients to be seated comfortably and women drape the anterior thorax when it's not being examined. Is it okay for you, ma'am, if I close the door and the window for your safety and free from distraction?
Yes.
Okay, ma'am, can you please sit comfortably? Next, positioning and preparation. Instruct client to void prior the start of procedure. A full bladder will make the examination uncomfortable and can reduce the accuracy of the fundamental height measurement. Okay, ma'am, can you void first? Position the client in a supine position with arms folded over the chest, or at the side, place a pillow underneath the client's knees to slightly flex the knees. The described position helps ensure abdominal muscles relaxation to avoid putting additional pressure over the abdomen. Next, cover the upper and lower body parts of a bed sheet, leaving the abdomen exposed from sigmoid process to just above the symphysis pubis. Confirm abdominal pain location if present. This allows full visualization and access to client's abdomen, verify presence and location of the abdominal pain to assess the area last. Next, inspection. Next is the inspection. Abdominal skin characteristics. Assess for the abdominal skin temperature, color, scars, striae, vascularities, rashes, ecchymosis, and other lesion. Note for its characteristic, size, shape, color, texture, location, and the presence of discharge. Next, umbilicus, bulges and mass. Observe for umbilical location, color, and contour, including presence of mass or bulges, suggesting of ventral hernia. Emphasize for any bulging or mass by having the clients flex his head. Abdominal contour and symmetry. Contour, while the client lies flat or supine on the bed, sit beside the client and look across the abdomen at a level slightly higher than the client's abdomen. Next is the symmetry. While standing on the foot of the bed, observe the abdominal symmetry while client lies in relaxed position. Next is measure abdominal girth. Measure the abdominal girth by placing a tape around the abdomen at the level of the umbilicus. Next is observe for the abdominal movement. Observe for abdominal respiratory movement, aortic pulsations, and peristalsis. Next, observe for abdominal movements. Observe for abdominal respiratory movement, aortic pulsation, and peristalsis. For the auscultation bowel sounds, ask for client's last intake, warm hands, and the diaphragm of the stethoscope. Recent intake could have increased peristaltic or activity, warm hands, and the stet to avoid startling the client of the coldness of the stet. Ma'am, when did you last intake?
2 hours ago.
Next, auscultate each of the 4 abdominal using the diaphragm for at least 1 minute beginning of the right lower quadrant, proceeding in a clockwise direction, noting for the intensity, pitch, and frequency of bowel sounds. Use light pressure when auscultating painful tenderness areas. the vascular sounds, use the bell of the stethoscope to listen for bruits and over the abdominal aorta and renal, iliac, and femoral arteries. Venous hum in the epigastric and umbilical areas. Use bell because bruit and venous hum are low-pitched sounds. See sites of auscultation in Next is peritoneal friction rubs. Use the diaphragm of the stethoscope to listen for friction rub over the liver and spleen. Use diaphragm because friction rub is high-pitched sound. See sites of auscultation. Next is percussion. Abdominal tone percuss several areas in each of the four quadrants to determine presence of tympani and dullness following systematic pattern. To determine areas of dullness and tympani, see pattern on percussion. Next is vertical liver span of mid-clavicular line. Lower border or liver dullness starting RLQ doing the mid-clavicular line percuss upward toward the liver. Note the change from tympani of dullness and mark this point. Upper border of liver dullness begin percussion on the right mid-clavicular line at area lung resonance around the third intercostal space. Continue downward until the percussion tone changes from resonance to liver dullness and mark this point. Next is measure the distance between the 2 points. Next is vertical liver span at mid-sternal line. Lower border of liver dullness starting above the umbilicus percuss upward toward the liver along the mid-sternal line. Noted the charge from tympani to dullness and mark the point. Next is the measure the distance between the points. Upper border of liver dullness. Begin percussion on the right mid-clavicular line at an area of a lung resonance around the third intercostal space. Continue downward until the percussion tone changes to form resonance to liver dullness and mark this point. lesson. Ask the client to take a deep breath and hold it while percussing from the RLQ along the mid-clavicular line towards the liver. Note the change from tympani to liver dullness and mark this point. Ask the client to exhale and measure distance of point of lower border liver dullness during deep inhalation from the right costal margin along the mid-clavicular line. Okay, ma'am, can you inhale? As shown in the LD video, reposition the patient to right side lying position with left knee flexed and identify the left anterior axillary line. To assess the site of the spleen, percuss the left anterior chest wall roughly from the border of cardiac dullness of the 6th rib to the anterior axillary line down to the costal margin. Percuss for tympani and dullness. Next, check for a splenic percussion sign. Percuss the lowest interspace in the left anterior axillary line, then ask the client to take a deep breath and percuss again. To evaluate for splenomegaly. Ma'am? Take a deep breath, ma'am. Liver blunt percussion. While client is lying supine, percuss the liver by placing the left hand flat against the lower right anterior rib cage. Use the ulnar side of the right fist to strike the left hand and attack for any pain. Next is kidney punch. Reposition the patient to sitting position and place left hand of the costovertebral angle of the 12th rib. Use the ulnar side of the right fist to strike the left hand and ask for any pain. Can you sit, ma'am? Sakit, ma'am. Really. For asides, test for shifting dullness. While client is in a supine position, percuss the flanks from the bed upward towards the umbilicus, noting the change from dullness to tympani and mark this point. Ma'am, pwede ko niyo matabangan ng idot na Next is fluid wave test. While client is in a supine position, ask the client or an assistant to press the edges of both hands firmly down the midline of the abdomen. Tap one flank sharply with fingertip. Feel for a fluid wave and transmit it across the abdomen to opposite flank. Next is palpation. Light palpation with client lying relaxed in a supine position. Begin with a light systematic palpation of all quadrants or 9 regions using the finger pads, initially avoiding any areas the patient had identified as painful. Observe for reports of pain, tenderness, guarding behavior, and masses. To assess for tenderness and presence of mass. I will palpate your abdomen. Next is deep palpation. Compress the abdomen to a maximum depth, 5 to 6 cm, using the palmar surface of the hands, initially avoiding the painful areas and palpated for muscle resistance or losses. Okay, next is umbilicus and surrounding area. Perform moderate palpation of the umbilical ring, noting for any presence of masses, swelling, nodules, and granulations. Next is the abdominal aorta. Use thumb and index finger or use both hands to develop, palpate the epigastrium slightly to the left midline for presence of abdominal aortic pulsations. To assess for abdominal aortic pulsation, which may indicate possibility of abdominal aortic aneurysm. Next is place the left hand under the client's back at the level of the 11 and 12 ribs, while the right hand is laid parallel to the right costal margin with fingertips pointing towards client's head. To assess for liver contour, surface, presence of nodules, tenderness, and irregularities. Next is instruct the client to take a deep breath, then compress the fingertips upward and inward to the lower border of the liver and assess for contour surface, presence of nodules, tenderness, and irregularity. To assess the liver contour surface, presence of nodules, tenderness, and irregularity. And can you inhale? Exhale. Inhale. Exhale. Next is spleen. Stand at the client right side, reach over the abdomen with left hand under the posterior lower rib and pull up, gently place the right hand below the left costal margins, pressed in towards the spleen. Ask the client to take a deep breath, then press inward and upward, using the right hand as the left hand provided support. Begin palpation below the costal margin and try to feel the tip or edge of the spleen as it comes down to meet the fingertips. Note for any tenderness and assess the splenic contour. Repeat the procedure with the client lying on the right side with legs somewhat flexed on the hips and knees as needed. To assess for splenomegaly, repositioning the patient allows better access to the spleen. Take a deep breath now. Stand at the patient's right side, place the left hand under the patient's right posterior flank and the right hand at the right costal margin of the MCL. Instruct the client to take a deep breath, then compress the fingers during deep inspiration. Ask the client to inhale and exhale. Hold his breath briefly and gradually release the pressure of right hand to feel the right kidney slipping beneath the fingers. Palpate the left kidney with the procedure reversed. Can you inhale and exhale? Inhale. Exhale. Exhale. Next is urinary bladder. Begin palpating of the symphysis pubis and move upward and outward to estimate bladder borders. Next is test for appendicitis or peritoneal irritation. Rebound tenderness, Blumberg sign, palpate deeply at 90 degrees into the abdomen halfway between the umbilicus and the anterior iliac crest. McBurney's point, then suddenly release pressure. Listen and watch for the client's expression of pain. Ask the client to describe which hurt more, the pressing or the releasing, and where on the abdomen the pain occurred. Katong pag-press na ako sa imong tiyan, ma'am. Asa ang sakit? Katong pag-press or katong nag-release na ako?
Press.
Pag-press. Okay, ma'am. Next is referred rebound tenderness, Robsing signs. Palpate deeply in the LQ and quickly release pressure. Assess for pain location. Next is test for SOA sign. Reposition to the left side lying position and a hyperextend client's right leg. Ay, sakit ma'am. Ano na bate? Ano? Test for obturator sign. Support the client's right knee and ankle at the flex hip and knee and rotate the leg internally and externally. Sakit ma'am. Hypersensitivity test. Position client supine with knees slightly flexed supported to by a pillow underneath, stroke the abdomen with a sharp object. Broken cotton, tip applicator or tongue plate. Or group the fold of skin with your thumb and index finger and quickly let go. Do this several times along the abdominal wall. Note for complaints or pain, exaggerated sensation. See images of the technique in the ma'am. Sakit. Thank you, ma'am. Okay, ma'am, for your findings. Physical exam findings, abdominal skin is tan, free of striae, scars, lesions, or rashes. Umbilicus is midline and recessed with no bulges. Abdomen is round, distended, symmetric, and without bulges or lumps. No diastasis, recti noted with neck flexion, no respiratory movement, peristaltic waves or aortic pulsations noted, bowel sounds 10 per minute, present with moderated pitch gargles times 4 quadrants, no bruits, venous humps, or friction rubs as auscultated. Percussion reveals generalized tympany with dullness over the liver, spleen, and descending colon. Liver span is 8 cm at the MCL and 6 cm at the MSL. No tenderness with blunt percussion over the liver or kidneys. No abdominal tenderness or guarding with light palpation. Mild tenderness over the sigmoid, aorta, cecum, and sigmoid colon with deep palpation. No rebound tenderness, palpable first mass noted in LLQ, liver, spleen, kidneys, and urinary bladder, not palpable. No evidence of fluid wave or shifting dullness. No palatable masses, negative SOA sign, obturator sign, Robsing sign, and Murphy sign. Ma'am, do you have any questions and clarifications to our assessment? Okay, ma'am, thank you for cooperation.